So thank you for inviting me to this webinar to talk about the problematic pediatric appendix. As mentioned, my name is Karen Lyons. I'm a pediatric radiologist at BC Children's in Vancouver and I'm affiliated with UBC. Oh, my slides. There we go. So our learning objectives for today are to identify the varied imaging appearances of acute pediatric appendicitis. We're going to think a little bit about the rationale for choosing different modalities, although Dr. Jamieson and Dr. Byrns are going to go into more detail with that. And then also think about some causes of false positives and false negatives in the imaging of the pediatric appendix. So acute appendicitis is the most common pediatric surgical emergency. It accounts for approximately 1/3 of children admitted with acute abdominal pain. The primary pathogenic event leading to acute appendicitis was long thought to be luminal obstruction, such as biofecalith, lymphoid hyperplasia, or foreign body. But more recent studies have demonstrated that many processes, including infection, trauma, ischemia, and dietary factors, can lead to bacterial invasion of the appendix, with obstruction actually being directly responsible for a relative minority. And although acute appendicitis can be diagnosed based on a classical clinical presentation, the diagnosis isn't always straightforward, especially in young patients who are unable to verbalize symptoms. And the rate of misdiagnosis at initial presentation is reported to be as high as almost 60% in children under 12 and almost 100% in children under 2. We want to try to avoid negative appendicectomies also. They are particularly common in postmenarchal females and can be associated with morbid complications in as many as 5% of cases and even death in a very small minority. So radiologists are frequently asked to evaluate the appendix of children and adolescents with acute abdominal pain. Our primary purpose is to reduce the rate of perforated appendicitis and non-therapeutic surgery by increasing diagnostic certainty, especially in clinically equivocal cases. And that accounts for about 35% of cases in young children and up to 45% of cases in adolescent females. So the most commonly used imaging modalities in this setting are ultrasound, CT, and MR. And MR being the least common, I suppose, in terms of generalized use. In general, imaging findings on all modalities supporting appendicitis are appendiceal enlargement, wall thickening, especially more than 2 to 3 millimeters, an appendicolith, periappendiceal fluid, and regional lymphadenopathy. Ultrasound, per se, can depict restricted mobility because it's sort of a dynamic study, hyperemia or absent vascularity, and increased echogenicity of the surrounding fat. And the CT and MR features are fairly similar, which is intraluminal fluid distension. And papers have found that greater than 2.6 millimeters is relatively sensitive. Mural hyperenhancement, and then periappendiceal fat stranding. Abdominal radiographs are non-specific and insensitive in the diagnosis of appendicitis and are only helpful in around 5% of cases. If we see a fecalith, as is in this case, in the setting of acute abdominal pain, that has a relatively high positive predictive value, but we only see it in about 5% of cases. And so the routine use of radiographs is really unnecessary if ultrasound or CT is planned and it's not cost effective or radiation effective. Ultrasound is a great test, non-invasive, low cost, there's no ionizing radiation. It's mobile and entails minimal patient preparation. The standard technique of graded compression is limited, though, in the setting of either abdominal wall rigidity, obesity, or deep positioning of the appendix. And false negative fractions as high as 2/3 have been reported when obesity and appendiceal perforation coexist. Now, the specificity of ultrasound almost uniformly exceeds 90% in pediatric appendicitis, and the sensitivity can get that high too, but it is more variable depending on who the operator is, and the literature says ranges between 40 and 90%. Appendicitis can't be entirely excluded unless we see all of the appendix, and that is dependent on patient and operator factors. Operator expertise is really the major determinant of diagnostic performance of ultrasound. And it does have sensitivity comparable to that of CT with expert operators. And this is just an ultrasound of a normal looking appendix. Notice that the thin wall, the good wall differentiation, the lumen is thin and collapsed. There's no surrounding increased echogenicity of the fat or fluid. Here is a classic example by comparison of appendicitis on ultrasound. So the appendix is enlarged, it measures a centimeter in diameter, the wall is hyperemic, it's thickened, and there is loss of wall differentiation with increased echogenicity of that surrounding fat. And here is another example of appendicitis with an appendiculus on CT. So CT has sensitivity and specificity in excess of 90%. It's less operator dependent. The appendix is more, I suppose, easily visualized, especially depending if it's in a difficult location. And it's probably better at delineating the complications of appendicitis, but significant disadvantages are ionizing radiation exposure, contrast media toxicity to the patient, and more to the environment we're learning. And it's a higher cost compared to ultrasound if cost comes into it. CT also doesn't allow the assessment of the mobility or compressibility of the appendix. And the normal appendiceal diameter is actually less well established on CT. And in kids, the paucity of intra-abdominal fat can make its identification difficult. MRI has excellent soft tissue contrast, multiplanar imaging. Downsides are that it's high cost, both in terms of money and opportunity cost. In our hospital, there's always the most pressure on MRI slots as compared to anything else in Canada. And also in some places, they may have limited availability on an emergency if you don't have a 24-hour techs. Recent studies have shown promise for MRI as a complementary technique after inconclusive ultrasound or even as a substitute with very high positive and negative predictive values. And this MRI depicts an example of acute appendicitis by MRI with an appendiculus, showing similar findings that you would see by CT. So now that we have thought about how we might image the patients, we will talk about some of the pitfalls in imaging the pediatric appendix, both false positives and false negatives. So thickening of a distal bowel loop is a common cause of false positive result on ultrasound, especially if the operator is inexperienced, and many of the other causes center around appendiceal enlargement. In terms of false negatives, they are usually accounted for by difficulty in visualizing the appendix. Its variability in location and length, as well as the location of the cecum, can make its identification difficult on imaging, especially by ultrasound. So the more generalized field of view of CT and MRI makes it a little easier to see the appendix along its length. And patient relation factors such as degree of peritoneal fat and increasing age are also significantly correlated with appendiceal visualization by CT. Tip appendicitis is an important cause of, or it makes up 5% of appendicitis, but it accounts for half of false negative ultrasound exams in one series. To avoid that, you need to visualize the entire length, unless the pretest probability is low enough that it would still be statistically unlikely. And now I'm just going to touch a bit more on the appendiceal enlargement without acute appendicitis. The most used upper limit for the normal maximum upper outer diameter of the appendix on ultrasound is 6 millimeters. And so that's helpful in that it is very rare for acute appendicitis to be associated with an appendix that measures less than 6 millimeters in diameter. So an appendiceal size threshold of 6 millimeters confers a sensitivity of almost 100% for appendicitis. But the normal range of appendiceal size is less well established on CT than ultrasound, somewhere between 2 and 10 millimeters, according to the literature. And the discrepancy in normal maximal appendiceal size between ultrasound and CT that probably applies at least in part to the compression technique that we use on ultrasound. And so while the use of a normal appendiceal size threshold is useful for excluding appendicitis, it's less valuable for confirming acute appendicitis if the size threshold is exceeded. You can get enlargement of the appendix In the absence of acute appendicitis in multiple conditions like reactive lymphoid hyperplasia, fecal impaction, cystic fibrosis, as well as mucocele of the appendix. And so in that setting, the appearance of the intraluminal contents, appendiceal wall, and periappendiceal tissues will help distinguish these conditions from acute appendicitis. And now I'm going to go through a couple of tricky examples. So here's an ultrasound image of a 14-year-old boy with abdominal pain. And so you can see that the appendix is enlarged. It's 8 millimeters maximum outer diameter. And that's related to luminal distension by impacted hyperechoic fecal material. There is no appendiceal wall thickening or periappendiceal inflammatory change to suggest complicating appendicitis. And so this was a case of fecal impaction. Intraluminal fecal material can dilate the appendix to a diameter of 10 millimeters, and this fecal material can become insupated and non-compressible. We can avoid a false positive diagnosis of appendicitis by recognizing the normal appearance of the appendiceal wall, which is thin, and the absence of periappendiceal inflammatory change. Here is another close in age, 15-year-old boy with chronic abdominal pain. And so we have an ultrasound and a CT. And in this case, we see appendiceal luminal distension by mucus, and that results in a mucocele. Notice that the appendiceal wall is very thin and there is no periappendiceal fat stranding either on CT or ultrasound. This was removed and it was found to be a low-grade mucinous tumor of the appendix. These can be caused by a variety of non-neoplastic, benign, neoplastic, or malignant conditions. And in the majority, they are discovered incidentally, but 25% of patients present with symptoms mimicking appendicitis. In the setting of abdominal pain, the absence of adjacent inflammatory change and wall thickening would suggest the diagnosis. They are fairly rare in children and adolescents and are more often seen in older adults over 50. Now here's another child who was having an outpatient who was having an abdominal ultrasound to evaluate their liver, and they had a history of chronic cough. And so what do we think about this appendix? It is enlarged, measuring 7.5 millimeters in diameter, and it is distended with material. Now, despite that, the wall is relatively thin. I know these images are a little dark to see the wall differentiation, but the wall is thin and there is no periappendiceal fat stranding. So this is actually a normal appendix in a patient with cystic fibrosis. So accumulation of intraluminal mucoviscous material can result in chronic distension of an otherwise normal appendix in a patient with cystic fibrosis. A prospective review of 31 asymptomatic children with CF showed a mean appendiceal diameter of 8.3 millimeters and a range of 4 to 14.5 millimeter. However, there was no associated appendiceal wall thickening, and they were all asymptomatic and were followed and did not have a missed appendicitis. On the other hand, this is a 10-year-old with CF and acute right iliac fossa pain. This is a different situation. So you still have that mucoviscous distension of the appendix, but around it, there is a lot of fat stranding and increased echogenicity of the fat, and the wall is thickened and there's some surrounding fluid. So this is a case of CF with appendicitis. Although children with cystic fibrosis have a lower lifetime incidence of acute appendicitis compared with the general population, only 1 to 2% compared to 7% of healthy people, those who do develop acute appendicitis are more likely to have delayed diagnosis and to develop complications such as appendiceal perforation. So early imaging is important. Here is a 3-year-old who presented with right lower quadrant pain, and an ultrasound was requested to evaluate for appendicitis. So this is an interesting case. You can see the appendix is larger than the 6 millimeters, 7.8 millimeters in diameter. And with it, there is, so the outer wall is thin. There is no associated periappendiceal fat stranding. And this is a case of reactive lymphoid hyperplasia. This is characterized by that hypoechoic cobblestone appearance of the inner abdominal wall or appendiceal wall on ultrasound, and then the absence of an intraluminal exudate or periappendiceal inflammatory change. The appendiceal wall is a repository of mucosal-associated lymphoid tissue, and reactive lymphoid hyperplasia is reported in association with upper respiratory tract infections and also specifically with infectious mononucleosis. And we see this, I think, more commonly in children than in adults because of um, the lymphoid hyperplasia. Here is a child, a 15-year-old, a 2-week history of abdominal pain, and this CT just shows an appendicolith, but the appendix is completely otherwise normal with no stranding and wall thickening. So this is a case of an appendicolith without appendicitis. And an appendicolith is seen by ultrasound or CT in 15 to 30% of cases of pediatric appendicitis. As an isolated finding, it is not diagnostic of appendicitis, and the relationship between an appendicolith and in an otherwise normal appendix and the future risk of appendicitis has long been controversial. Some more recent literature suggests that children with an appendicolith in an otherwise normal appendix are not at significantly increased risk of later developing acute appendicitis, arguing against the need for prophylactic appendicectomy or even follow-up imaging. This 10-year-old child had had a bone marrow transplant for ALL, and they presented with right lower quadrant abdominal pain, and so they had an ultrasound followed by a CT. So you can see the appendix is enlarged, measuring 12.6 millimeters. There is loss of wall differentiation and surrounding increased echogenicity of the fat. On the CT, you see the correlate of fat stranding in the right iliac fossa, as well as enlargement and distension of the appendix. This was a case of neutropenic appendicitis in this child who was immune suppressed. And so contiguous involvement of the appendix can occur with tiflitis, in which case appropriate recognition can guide a therapeutic trial of antimicrobials and bowel rest and avoid the risk of surgery in the setting of neutropenia. Appendiceal inflammation in inflammatory bowel disease is also associated with contiguous involvement of the terminal ileum or cecum, and so that would be a tip in that scenario. Isolated granulomatous appendicitis in the absence of a known diagnosis of Crohn's disease is very rare. And when it happens, it is associated with around a 20% chance of recurrence at other sites. This is an interesting little false positive. So this is a 15-year-old girl who presented with acute right lower quadrant pain. And when she, as normally happens, she was referred for ultrasound, query appendicitis. The tech that scanned her could not find her appendicitis, or her appendix, I should say, but it immediately asked the patient, where do you feel pain, and put the probe down. And this ultrasound that you see is exactly where she was tender. And so you can see there is focal increased echogenicity of that omental fat. And so that prompted referral for a CT to see if they could identify the cause of the inflammation. And those arrows on the CT, on the coronal and the axial, point to that same area that we saw by ultrasound, which is a rounded area of stranding in the omental fat. This is very classic for an omental infarct and is a mimic of appendicitis, and typically is treated, I think, with non-steroidal anti-inflammatories. And my last case is of a 9-year-old with abdominal pain. And so you can see here the proximal appendix. It looks completely normal. It's normal in size, normal wall differentiation and wall thickness. And then the tip is not normal. It's enlarged and the wall is thickened. It's distended with mucus. There is increased echogenicity of the fat around it. And so this is a case of tip appendicitis. So in summary, we have reviewed the imaging findings of appendicitis. We've talked a little bit about the diagnostic tools that are available to us as radiologists and why we might think about them for different patients. We have reviewed a smattering of false positives and false negatives with imaging examples of both. And I'll conclude by thanking you for listening.
We are going to talk about imaging recommendations for pediatric appendicitis. And these are our learning objectives. We're going to talk about the role of different modalities in imaging the pediatric appendix, discuss a collaborative pathway for imaging the appendix, working with general surgeons and our emergency room colleagues, and then summarize the ultrasound, CT, and MRI protocols using for imaging the appendix. And so Dr. Byrns is going to talk now about his clinical perspective.
Hi, good afternoon, everyone. So very briefly, we'll just go over some of the clinical context of us requesting imaging. And I'm hoping all of the physicians who are referring to us as surgeons are following some form of a pathway. But in essence, as with everything should start with a complete history and physical. And that will usually identify patients if we do have to silo them into what we can describe as 3 separate groups. One where they have a suspected low likelihood of having appendicitis, an intermediate group where we're uncertain and perhaps need more information or more evidence, and the final silo where we're actually quite confident just based on history and physical alone that this patient has appendicitis. So just to give an example of some of the scoring systems, and there's several of them, the Alvarado, or is also known as the Mantrell score. That's just a mnemonic for remembering each of the components of it. But there's also like the Lintula score, the Xenakis scoring system, the pediatric appendicitis, the modified pediatric appendicitis scoring system. I think these are very useful for reminding diagnosticians what the elements or the most predictive components of both the history and the physical examination are for making a reliable prediction as to whether this patient has or does not have appendicitis. And as you can see here on this is the example of the Alvarado score. It's based on both history and laboratory, as well as symptoms such as temperature or rebound tenderness. And so for patients who have typically a score greater than 5, by summing all of these factors, despite this, there's still some discordance with the history or some uncertainty, then that's often when additional information in the form of imaging is required. And it can help reassure those practitioners when the score is very low that the likelihood is quite low, to provide some reassurance and oftentimes just symptomatic management and instructions to return if symptoms worsen. And then, of course, if the score is very high, then to sometimes directly involve surgeons or subspecialists to assess the patient, as there may be an opportunity to forego further investigations. So these scoring systems are very useful for just sort of helping to categorize those patients. And then when they are siloed into that intermediate risk category, that's often when we need more information. I think, is there anything on the next slide there, Lucy? Mm-hmm. Yeah, I think that just summarizes exactly that, just that intermediate risk group.
Great, thank you. So we can talk about some of the modalities. Karen's talked already about X-ray and how it's not sensitive or specific for diagnosis of appendicitis, but it can be used to look for alternate causes of pain, such as constipation or occasionally lower lobe pneumonia. In patients with low risk, it's generally not indicated, but it can help identify complications such as bowel obstruction or perforation. Ultrasound, as Karen mentioned, is the first-line imaging test. It's simple, rapid, easily available, and no radiation. And the accuracy really depends on the operator and patient-specific factors such as obesity. One of the limitations is diagnosing perforated appendicitis, particularly if we're not seeing the distal portion of the appendix. These are some measurements that I found that are interesting. For the mean measurement of the appendix is 5.6 millimeters. However, as Karen mentioned, a normal appendix can actually measure a lot larger, with 38% of a normal appendix measuring larger than 6 millimeters. And the diameter of the appendix can increase 0.4 millimeters per year until about 6 or 7 millimeters, after which it's stable. So basically 6 to 7 millimeters should not be used in isolation to diagnose appendicitis, and that it's important to use the other factors such as echogenic, periappendiceal fat, and periappendiceal fluid, and other inflammatory findings. So 2 of the most sensitive findings of periappendiceal inflammatory changes are the periappendiceal echogenic fat and periappendiceal localized fluid, and those can help put it together with the size of the appendix in terms of diagnosing free fluid or diagnosing appendicitis. The other ones being free fluid or thickened loops of bowel or enlarged lymph nodes. This is an example of periappendiceal echogenic fat, and this is shown to be seen in 90% of patients with acute appendicitis. At the Stollery, we created a pathway. Actually, I'll talk about the pathway next. This is our local ultrasound protocol. It's a targeted ultrasound of the appendix and abdomen and pelvis. I don't need to go through all of this, but it's basically targeted ultrasound of the right lower quadrant, looking at the gut signature, terminal ileum, ileocecal valve, making sure to look at all of the appendix in different planes, and then measuring with and without compression, looking for any hyperemia, surrounding fluid collections, and then documenting that echogenic fat or mesenteric adenitis, and then any surrounding lymph nodes, any area of concern that the patient has, and then the terminal ileum and cecum. In terms of the non-visualized appendix, which is not uncommon, particularly given patient body habitus, several studies have shown that a non-visualized appendix with no inflammatory changes in the right lower quadrant has a very high negative predictive value, and that further imaging with CT or in MRI, depending on your site, is less likely to be contributory. CT has a high sensitivity and specificity for diagnosing appendicitis, but if the appendix is not visualized, as we mentioned, with no inflammatory change, then the CT predictive value is quite low, or the negative predictive value is similar to that of a CT with a normal appendix. And every effort should be made to prevent the need for CT when not necessary. Oral contrast is generally not indicated. It can increase scan time, increased rates of emesis, particularly in kids who have a small bowel obstruction, and rectal contrast is not indicated. CT can be a good option in addition to ultrasound to look for complications such as like a surrounding abscess or perforation. This is our CT. We do intravenous contrast enhanced abdomen and pelvis. Some centers do a localized CT from L2 or L3 based on height adjusted distance from the umbilicus to the pubic symphysis. And unenhanced CT of the abdomen and pelvis could be done if needed, the limitations being that it doesn't detect or assess for abscess formation as well. This is our local CT protocol for contrast with IV and no oral with multiplanar ray formation. There's no data to suggest that CT with and without contrast, so two separate scans, increase detection. And we know it doubles the radiation dose. In terms of radiation from CT for kids, when talking to parents, sometimes they're concerned about the risks of radiation. We know that the average Canadian is exposed to about 2 to 4 millisieverts of radiation from natural resources per year. And variable dose and CT exams, depending on where you are, what type of scanner you have, what dose protocols you're using, typically 2 to 8 millisieverts, and much lower than previous years with newer scanners and faster scan time. It's comparable to about 2 to 3 years of natural background radiation. And as a comparison, a typical chest X-ray is about 0.1 millisieverts. And in pediatric radiology, we always talk about ALERA, which means as low as reasonably achievable. So we want to use the lowest dose or the least amount of radiation. And ideally, that means ultrasound to assess what we need to do. Children suffer a larger radiation dose compared to adults using the same CT protocol, and this is because of their longer life expectancy to develop complications. So they have a larger window of time to express radiation damage. And children can receive a higher radiation dose if not adjusted for their smaller size. They are more susceptible to the effects of radiation than adults. And some studies have shown that there's an associated lifetime cancer risk of a pediatric abdominal CT of up to 0.16%. Some organs have higher radiosensitivity, including breast, thyroid, colon, and lungs. And we know there's no low dose threshold for inducing cancers. Imaging Gently is a good website if you're interested in getting further information on this or providing it to patients. And it also provides some low dose CT protocols. MRI is a great alternative to imaging the appendix when we can't see it with ultrasound. However, it's really limited by availability. And in our site, we started doing it a couple of years ago and then basically stopped due to limited MRI resources in our hospital and just the long wait list for MRI. And then realistically, we don't want to sedate kids for it. And we want faster access with CT if we're concerned about complications such as an abscess or any surrounding complications. We can use certain sequences, including diffusion and contrast, to improve the accuracy. And then there's several studies that show you actually don't need contrast. And things like diffusion and other sequences can help improve accuracy without giving contrast. And it's very center specific in terms of when MRI is used for appendicitis, largely due to MRI resources and volume. This was our MRI protocol when we were doing the occasional pediatric appendicitis MRI. Currently, we do the occasional pregnant person with appendicitis. We have an adult-specific protocol. This was a limited protocol we had before. Ideally, if you can make the diagnosis without gadolinium, that's even better, cheaper and faster. And diffusion, similar to MR enterography, can be sensitive for looking at active inflammation. So we created a pathway with our pediatric general surgery and emergency colleagues. And the background is that we're a large city with multiple hospitals, and children aren't always sent to this Stollery for assessment and imaging and to see children's surgeons. And too many CT exams were done in community hospitals. So our goal was to decrease the volume of CT imaging peripherally. Many ultrasounds as well were done in the community and then repeated when they were seen by a pediatric surgeon here. So our goal was to stop unnecessary CT and ultrasound exams. This is our pathway, and it's specific to our site, and it's, I think, every community hospital or children's hospital can develop their own pathway. This has worked for us in that it has limited the number of CT exams. Prior to this being instituted, so we've got a resident who's doing a QA project that has looked at the number of CTs prior to this pathway being instituted, and then after this being instituted. This was done in about May of last year, and he's in the process but has already found significantly decreased number of CT exams in the community after this pathway has been instituted. The big changes are that less than 12 children in the community hospitals are just sent to the Stollery for imaging. That way we have experienced ultrasound techs who are used to imaging children who are kicking and mobile and in pain. And children over the age of 12 can be imaged in the community. If it's an indeterminate ultrasound and CT may be requested, then they're sent to the Stollery where they can be assessed by pediatric emergency doctors and have a surgery consult and have a more comprehensive clinical exam and looking at laboratory values. So this has really decreased the number of CT exams throughout the city. So in summary, we talk about low risk, intermediate risk, and high clinical risk. Ideally, the kids who should be imaged are the intermediate clinical risk, where it's indeterminate. The high risk ones can often go straight to surgery, and I'm sure Simon can talk about that. I'm sure it's patient and surgeon specific. And even in those high risk patients, ultrasound would still be the first test for confirmation of appendicitis. And that if there are complications or further imaging, CT or MRI may be useful. Thank you.